Before we get started on Medicare, I always think that it's really a good idea to start at the very beginning. And here you can see President Johnson signing Medicare into law. This is a photograph from the New York Times from July 31, 1965. And you can see President Johnson seated next to President Truman, who was the first president to propose Medicare for everyone in the United States. And on the right, you can see that that's President Truman's Medicare card. He was the very first American to qualify to get Medicare. Now you notice that in that photograph, President Johnson and President Truman are the only two people who are not smiling. Well, I think the reason why they're not smiling is because they knew the sausage making that it took in order to pass Medicare. In his book, Paul Starr talks about the politics of accommodation and what it took to pass Medicare into law. You know, Medicare didn't just happen in 1965. It actually took 50 years of politicking in order to get Medicare passed into law. And it was a very long, hard-fought 50-year fight. And to win, President Johnson had to accommodate very, very powerful factions, including hospitals, the not-for-profit health insurance companies called the Blues at that time, the American Medical Association, which was the organization of physicians, virulently opposed to the passage of Medicare, the Republicans, who were not very happy to give out handouts to poor people, and the Southern Democrats, who were certainly not very happy to give out handouts to blacks. Now, the final arrangement of Medicare surrendered the terms and costs of the program to these players. And this is something that I want you to keep in your mind as we go through the next 30 minutes of this presentation. It's that these players have been the ones that have decided the cost and terms of the whole program. And as a result, these interests, these players, shaped Medicare to maximize their profits at the expense of taxpayers since 1965 to today. So keep this in mind. All right, so as you know, Medicare was passed in 1965 to cover the healthcare needs of people who were 65 and over. And it started as Part A and B, and it was also called original or traditional Medicare. Now there's a Part A and a Part B, and then the Part B supplemental. Part A, as you know, is automatic medical coverage. So if you have paid into Social Security for 10 years, you automatically are enrolled into Part A. You don't really need to do anything, you're automatically enrolled. There are no monthly premiums, and it pays 100% of your hospital costs. But there's a lot of fine print in this, and we'll get to that fine print in a minute. Part B was voluntary health insurance, so you don't automatically get it. You have to pay premiums, and premiums depend on your income. And it covers 80% of outpatient costs. So it covers 80% of your clinic visits, your doctor visits, your x-rays, your lab work, 80%. And because people in Medicare were on the hook for that 20%, then we got something known as Part B supplemental, which is the private health insurance that pays for that 20% that Part B doesn't cover. And this is often paid out of pocket by Medicare beneficiaries, or it can be paid by your employer if you have a good employer with good retiree benefits, or your union if you have a good union, or Medi-Cal if you're dual eligible. Now, over the years, more and more people qualified. So, for example, people with end-stage renal disease, such as kidney dialysis, people with ALS, that's Lou Gehrig's disease, people on Social Security income after 2 years. So, more and more were added. Part C, D, and Part C, which eventually became Medicare Advantage. I don't know if we want to bring the laptop over here, so that or maybe I should go over there.
Is this good now?
Yeah.
Okay.
Okay, well, let's try. So the Part C was the private health insurance option that President Clinton signed into law so that people who signed up for Medicare could also, instead of doing the Part A and B, could choose to have a private health insurance manage their Medicare. And ostensibly, this was to improve outcomes and lower costs because we know that private businesses always do that so much better, right, than the government. Then Part D, where monthly premiums would pay for your prescription drug costs, and this was signed into law by President Bush in 2003. And in 2003, that same law also made Part C into Medicare Advantage, and those were private health insurance options with low or very low monthly premiums that gave you extras such as hearing, vision, and dental, as well as you had to accept the narrow networks and the prior authorizations. So that's a little overview of Medicare. Now, total Medicare spending, however, has really, really gone up since its inception in 1965, which started with about $10 billion budget. In 1970, you can see it went down a little bit, but ever since then, every 5 years, it keeps going up and up and, oof. Okay, and up, so that the budget, which started in 1965 as $10 billion, today is $1,000 billion. Now, remember what I said about those special interests and those powerful factions? At the end of the day, somebody takes home $1,000 billion. Now, you can say, well, but the number of beneficiaries has also been going up as well, which is true, so let's take a look at that. All right, so Medicare started in 1965, and by 1966, there were 20 million beneficiaries that were enrolled into Medicare actually in 10 years using index cards, so it's really quite a feat. And with every year, it keeps going higher and higher and higher and higher and higher, so that you can see that it started with 20 million beneficiaries in 1965, and today we have about 65 million beneficiaries in Medicare. And while the total number of Medicare beneficiaries has increased threefold, the costs have increased 100-fold. So the big question is, why is spending going up? Well, according to American health policy experts, there are two reasons why healthcare costs in the United States have gone up. Number one is greedy American doctors order too many tests, perform too many procedures. And number two, greedy American patients see too many doctors, ask for too many tests and too many procedures. And here you see the typical greedy American patient hooked up to his chef salad. I think it's his IV. I can't really see it from here, but it's his condensed chef salad, right, through his IV. This is known as fee-for-service. Now, what is fee-for-service? Fee-for-service is actually really quite simple. Under traditional Medicare, which is the original Medicare A and B, the way that physicians are reimbursed is through this reimbursement mechanism known as fee-for-service. Really quite simple. Traditional Medicare pays the doctors directly. So if you have traditional Medicare, you go to your doctor performs a certain service, and then the doctor bills Medicare for that service, and Medicare pays the doctor directly. Very, very, very simple. That's fee-for-service. Very direct loop. Now, there are many myths, however, about fee-for-service. One myth says that our costs are high because we use fee-for-service. But when you look at 12 other peer nations who also use fee-for-service, you can see there from 1983 to 2017, the US healthcare spending per capita or per GDP, you can see the black line on the very top trending up much, much higher than the other ones. And all the other countries, the other peer nations that also use fee-for-service spend much, much less in healthcare spending as a percentage of their GDP, gross domestic product, than the United States. So it really cannot be because of fee-for-service. Well, maybe our costs are high because we just get too much care, right? Well, in the United States, if you ask patients If you have had to forego or skip care due to cost in the past 12 months, you can see that 33% of Americans say that they skip care due to cost. Compare that with other countries, with Switzerland, with France, with Canada. In the UK, only 7% of individuals say that they skip care due to cost, as opposed to 33% in the United States. So I think that we can bust the myth of fee-for-service being the cause of high costs here in the United States. What really drives up costs? Prices. If you have your appendix removed here in the United States, you're going to pay a whole lot more here in the US than you are going to pay in Canada or in France or in Switzerland. Administrative waste, 30% of our healthcare dollars goes to administration only. We outspend every other country in administrative waste by about twice as much. Fragmentation, our system is so fragmented and that leads to increased costs, as does consolidation. That's the small hospital that gets gobbled up by the bigger hospital that gets gobbled up by the even bigger hospital. All of these things drive costs up, not fee-for-service. Now, despite this, since 1970, the way to control costs in Medicare, according to our experts, is to do the following. Medicare will pay a middleman a capitation fee that is a set amount to be between Medicare and the doctor, and then share the risk and decide who gets what, where, when. And then pays the doctor, the hospital, or the other providers, and then keeps a certain percentage of the leftovers. Now, these middlemen have been called health maintenance organizations, Medicare Advantage, accountable care organizations, and as we will find out, ACO REACH. So here you see that our health policy experts believe that by inserting a middleman, we're going to control costs. Now, anybody here in this room believe that inserting a middleman will ever control costs? I didn't think so. So, another way of describing giving these public funds to a for-profit middleman is privatization. And here we can see Medicare privatization before 2003 looked something like this. The vast majority of people on Medicare chose to stay on traditional, original A and B Medicare. That's the blue part of the pie. You see that that's the vast majority of individuals before 2003 chose to stay in original Medicare. And a very small slice of the pie, that green slice, were individuals that wanted that Part C, that they wanted an insurance company to manage their care. Now let's fast forward to 2023, and you can see that 50% of individuals have chosen something called Medicare Advantage. Now, a few words about Medicare Advantage. I am not here at all to tell you to switch out of Medicare Advantage. That is not my job. I would not recommend that. Most people that have Medicare Advantage are actually quite content with their Medicare Advantage. So that's not my job today. My job today, however, is to tell you that 50% of individuals choose Medicare Advantage, such as United Healthcare, to manage their Medicare, also Humana, Aetna, Kaiser Choice, or Kaiser Advantage, I think it's called. And that Medicare Advantage, however, is overpaid by the federal government anywhere from $88 billion to $140 billion per year. Wow. So it's a lot of money that Medicare Advantage is getting from the federal government as overpayments. Now, the other half of Medicare...
I'm sorry, what is an overpayment?
An overpayment, that means that the government, instead of paying for a beneficiary for $1,000, pays $2,000 when the insurance company is only giving $1,000 worth of health care. So thank you for that. So the other 50% choose Medicare, traditional Medicare. And you can see that up to 50% are now choosing Medicare Advantage. Now we're going to spend most of the rest of the time talking about traditional Medicare because we see that Medicare is already half privatized, right? Half of Medicare is already in the hands of for-profit commercial insurance companies. That's privatization. The other half is under threat of being privatized, and that's what we're going to be looking at in the next few minutes. Now, why is it that so many seniors choose Medicare Advantage, right? Well, because if you look at how much seniors have to pay in 2023 to stay on traditional Medicare, and this is the fine print, the Part A deductible is $1,600 per hospitalization per year. The Part B premiums are going to be at least $2,000 per year, and it can be more depending on your income. The Part B Medigap, to pay for that 20% that Part B doesn't pay for, can be up to $3,000 per year. The Part D premiums are about $2,400. That's to pay for your prescription drugs. So in total, it will cost a senior an average of about $8,800 a year just to stay on traditional Medicare, and there are no out-of-pocket caps. So it's very, very expensive. And that's the reason why 50% of beneficiaries have chosen Medicare Advantage, because it is less expensive. However, as we know, you have to accept the narrow networks and prior authorizations. So, to control costs in Medicare, what Medicare has decided, the federal government has decided to do, is in Medicare Advantage, do the thing called capitation, which are the upfront payments that they give to insurance companies to then decide how to manage the care of seniors. That's Medicare Advantage. Now, on the other side, on the traditional Medicare side, to control costs, Medicare has come up with something called value-based payment models. And this is what we're going to be talking about. This is the way that Medicare has decided it's going to control costs in traditional Medicare. Remember traditional Medicare fee-for-service, right? Okay, so we all agree that the goal of value in healthcare is good. Nobody's going to argue that. Value is a good thing. But how do we define value? How do we measure value? And finally, should value be the stick by which medical care is measured, reimbursed, and rewarded if we can't define it or measure it? And finally, what is value-based payment? So, my guess is that most of you recognize this. Most of you have seen The Godfather. Okay, if anybody here hasn't seen The Godfather, you should, rent it on Netflix. I'm sure you can. Do that tonight, and all of this will become perfectly clear to you. So I like to think of value-based payment like The Godfather. And then, remember Fredo, the incompetent son? Okay, so he's something called ACO REACH, and we're going to talk about that in a minute. Spoiler alert, value-based payment is the new managed care for traditional Medicare, codified by the Affordable Care Act in 2010 to move doctors away from fee-for-service towards value-based care. It has little to do with care. See, this is where all the confusion starts. We think value-based care must have something to do with value. Well, no. Or with care. It has little to do with care, nothing to do with value, a lot more to do with payment, and everything to do with managed care. Value-based payment does three things. It inserts a middleman in traditional Medicare. It uses performance measures, and it sets spending targets. And we're going to go through these one by one, so hopefully you will understand what I mean by this. Number one, all value-based payment models insert a for-profit middleman in traditional Medicare. Remember traditional Medicare where I showed you that there was no middleman? Well, now in traditional Medicare, there is a middleman. And it isn't just that there's a middleman there, but it's also doctors now share the financial risk of caring for that senior. I'll tell you in a second what that looks like, but it's just not just the middleman now, it's also the doctor that's sharing the risk of ensuring and taking care of that patient. Number two, all value-based models tie primary care doctors' financial incentives to performance measures. So for example, quality of care. Well, that's not a bad thing, right? Let's see, make sure that all your patients have good blood pressure control. But, okay, we're gonna concentrate on blood pressure, but we're not gonna think about diabetes control. Or we're gonna look at chest pain, but we're not gonna look at something else. So it's very difficult for to choose which things we're gonna value. And then, yes, other performance measures. So for example, how many of your patients get the flu shot? It's a great thing. I recommend everybody get their flu shot in the winter, everybody get their COVID vaccines. However, we know that healthcare is determined by so much more than just flu shots, right? It's determined by where you live, if you have transportation, if you have access to healthcare, if you live in green space, if you live in a healthy environment, if you live in a healthy family, so forth. And then, of course, to keep costs down. So how well physicians perform determines how much of the savings they share. Now, we need more and not fewer primary care doctors. And I just want to take a little break here and just to let you know that I retired from UCSF. Well, I retired from being a pediatrician after 30 years of practicing. Trust me, I had to learn a ton about Medicare because I really did not take care of Medicare patients during my career. But I have to say that the thousands of physicians that I have had the honor of working with all wanted to be doctors because they wanted to take care of people, they wanted to heal, and they saw this as a calling. That's why I went into medicine, and I think most physicians go into medicine for that reason. And I think that they are trapped in a really, really awful system right now. Number 3, all value-based payment models set spending targets, they're also known as benchmarks, for doctors and middlemen. So what does this mean? Say that you have Mr. Smith, and Mr. Smith gets from Medicare $1,000. That's the spending target. If the doctor and the middleman only spend $900, like they come in under that benchmark, under that spending target, then they get to share a certain percentage of the $100 that they save on that patient, right? However, if they spend above that spending target, say they spend $1,100, then, depending on the financial arrangement they have with Medicare, they might owe Medicare money, right? So that's why if they come in under the target, they increase their profits, and if they come in over the target, they might owe Medicare money. So, financial incentives incentivize doctors and middlemen to deny and skimp care to maximize their profit, because how else are you going to come in under that spending target? You're going to be, skimping on care. Maybe you don't really need that specialist. Maybe you don't need to go to that fancy hospital or that fancy center of excellence, right? They're going to seek healthy patients who cost little, right? So they know Mr. Smith costs $900, but they know Mrs. Smith only costs $500. Ooh, we're going to go after Mrs. Smith because we're going to be saving a lot of money on Mrs. Smith. But you're going to be avoiding the sick ones who cost more. So Mr. Jones, who has a chronic illness, you know that he spends $2,000 a month, he's going to cost $2,000 a month. You're going to be avoiding Mr. Jones as much as possible, and you're not going to be taking care of those patients that cost a lot of money. And then you're going to do something called upcoding that makes healthy patients look sick on paper. And upcoding, I don't know how many of you know this, but and this is how Medicare Advantage plans are getting overpaid, and that is because they say that they're going to get $1,000 for Mr. Smith, but they say that Mr. Smith, instead of having that controllable blood pressure, really has uncontrollable blood pressure, also has some chest pain, and several years ago had a mild stroke. Every single time you add on a diagnosis, Medicare is going to give you more and more and more money for Mr. Smith. And that's called upcoding, despite the fact that Mr. Smith doesn't need any of those extra things to take care of him. He's just going to cost that $1,000 a month. But that Medicare Advantage company is getting the $2,000 or the $3,000, or even much, much more than they should be getting. And that's called upcoding, and that's one of the ways that Medicare Advantage gets overpaid. Finally, the middleman might decide to avoid doctors that take care of sick people. So say, for example, Dr. Shore, who takes care of marginalized populations, right? He takes care of people that are always going to cost $2,000 or $3,000. And the middleman is just going to say, you know what, Dr. Shore, you're just never going to make us money, so we're just going to drop you and all your patients from the plan. So that's what's happening as well. The 1-minute value-based payment elevator speeches, it has nothing to do with value. It inserts a for-profit middleman between Medicare and the beneficiaries on traditional Medicare. It shifts the financial risk from Medicare to doctors. It rewards doctors financially for meeting performance measures and for spending under those spending targets. It's managed care all over again. It incentivizes cheating, skimping on care, cherry-picking healthy patients, lemon-dropping sick ones, and upcoding, making healthy patients look sicker on paper than they really are. It has little to do with care, nothing to do with value, a lot more to do with payment, and everything to do with managed care. Now, remember the Godfather. We're going to be talking about ACO REACH, because ACO REACH is a typical value-based model. It started as direct contracting entities under the Trump administration, and it was green-lighted by the Biden administration and renamed as ACO, Accountable Care Organizations, REACH, Reaching Equity, Access, and Community Health. However, it inserts a for-profit middleman, which is now called an ACO REACH, that agrees to share the risk to provide care for seniors on traditional Medicare. That's what ACO REACH is. It's just another middleman. And what are these ACO REACH middlemen? Well, virtually any type of company can apply to be an ACO REACH, including commercial insurers, private equity firms, venture capital investors. So the same commercial insurers that are the Medicare Advantage insurers can also be an ACO REACH. And applicants are approved without any input from Congress. But the big question is, how do you enroll millions of seniors on traditional Medicare into an ACO REACH, right? These are seniors that say, I reject Medicare Advantage, I do not want a middleman, I just want to be able to choose my own doctor, I want to be able to choose my own hospital, right? Well, you don't tell them. Over 2 million seniors and people with disabilities on traditional Medicare are being automatically enrolled into ACO REACH without their knowledge or consent, because this is how it's happened. Oh wow, okay. All right, so this is a problem.
I'll get you back.
What's that? Yeah, on that side. Okay, yes, we're getting to like the fever pitch here. Okay. How? Well, what happens is they do it through their primary care doctors, because it's the primary care doctors that are signing contracts with ACO REACH, and then all of the patients in that doctor's panel get automatically enrolled into the ACO REACH. And that's how it's happening, without their knowledge, without their consent. Whoa, okay. Oh. So I don't know if you need like different batteries here.
Which, next slide is?
What's that? Well, it's going to be, all right, ACO REACH threatened, this is it, we're here. Senior choice, senior medical care, and even the Medicare Trust Fund. Senior choice because Part A and B beneficiaries are enrolled without their knowledge or consent. their medical care because doctors have financial incentives to skip on care to increase profits. Doctors are going to be cherry-picking healthy patients and dropping sick ones. And even the Medicare Trust Fund, because under traditional Medicare, 98 cents of every dollar goes to pay for medical care. Only 2% goes to overhead. Under ACO REACH, these ACO REACH corporations can spend as little as 60 cents of every healthcare dollar on medical care, keeping up to 25 to 40% for overhead and profit. And what's next for seniors? Well, according to the Centers for Medicare and Medicaid Services from their website, all Medicare fee-for-service beneficiaries will be in a care relationship with accountability for quality and total cost of care by 2030. This means that every beneficiary on traditional Medicare is going to be in some kind of a value-based shared risk payment model by 2030. So it's not just Medicare Advantage that has been privatized, but all of Medicare is threatened by privatization. So who comes up with these models anyway?
Yes.
Right. In 2010, the Affordable Care Act established something known as the Innovation Center, with a mandate to test value-based payment models to reduce Medicare spending while improving or at least not worsening care for beneficiaries on traditional Medicare. They were supposed to transition away from fee-for-service towards value-based care. And they could scale any model that fulfilled its criteria to all of Medicare without congressional approval. They got a $10 billion budget every 10 years, no matter what. It's called mandatory funding, so they don't have to go through appropriations. They just get this money no matter what. They have run or are running 83 of these models. They're currently running 32 models, including ACO REACH. And the latest financial evaluation from the Congressional Budget Office, that was just published like 2 weeks ago, says that the Congressional Budget Office currently estimates that the center's activities increased direct spending by $5.4 billion. So they didn't save Medicare any money. In fact, they are costing Medicare money. And not only did they think that they were going to be saving money, but they are now saying that it's going to increase that spending during the first 10 years since 2010, and they will continue to do so into its second decade. Now, while they've been wasting money and wasting time, what we've done is really remarkable. Over 300 organizations have signed resolutions opposing ACO REACH, including 23 California Central committees, county committees, 5 central labor councils here in California, and on September 7th, the California State Legislature passed Assembly Joint Resolution 4, which puts California as the first state in the country to go on record opposing ACO REACH and corporate profiteering in Medicare. So this is a copy of Assembly Joint Resolution 4 that will request President Biden to immediately end ACO REACH and corporate profiteering in Medicare. And it was introduced by Assemblywoman Chavo early in April. It passed Assembly Health. It was adopted by the Assembly, then it passed Senate Health, and it was adopted by the full Senate and chaptered by the Secretary of State September 14th, and it was sent to President Biden. Now, next steps. We're going to be taking Assembly Joint Resolution 4 to members of Congress, to our Democratic congressional delegation, any Republicans that want to as well. We're going to be setting up meetings with them, and what we want to do is we want to educate them about ACO REACH and value-based payment models that are threatening the care, choice, and solvency of Medicare, ask them to sign a pledge in support of AJR 4, urging President Biden to end ACO REACH, calling on CMS Administrator Shakita Brooks-LaSure to reconsider all value-based models coming out of the Innovation Center, and then to ask the Innovation Center, well, why don't you run a single-payer-based model instead? And if you know of other faith organizations that want to get involved or would like to hear this talk, I promise to bring a better clicker next time. Please let me know. This is a sample letter that says, Dear Member of Congress, Assembly Joint Resolution 4, if you want to take a photo of this and send a letter like this to your Member of Congress, Assembly Joint Resolution 4, passed by the California State Legislature, urges President Biden to end ACO REACH, a value-based payment model that threatens the choice and care for seniors like me on Medicare and threatens the solvency of the Medicare Trust Fund for future Medicare beneficiaries. Sign the pledge that urges President Biden to end ACO REACH, calls on Center for Medicare and Medicaid Services Administrator Brooks LaSure to reconsider all value-based payment models and requests Innovation Center Director Fowler to test a single-payer model in 2024. You can sign, you can print your name, you can date it, and make sure you put in your address. So this PowerPoint slide show will be available to anybody who would like it. Dr. Shore has copies of it. And for those of you that are interested in finding out more about it, you can read it there. And that's it. Thank you so much, and I'd be happy to answer any questions.